Okay, thanks. Hi, everybody, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. We're pleased to be hosting today's webinar in honor of National Pride Month and are very grateful to Genentech for the generous support which helps us make this event possible. I'm your host, Deborah Foreman. I'm the Educational Programs Coordinator for the Foundation, and I'm joined by Dr. William Conte, who will be presenting today's topic, which is LGBTQ plus health disparities in MS. After his presentation, we'll open it up to your questions and comments. Now I'm delighted to introduce him. Dr. William L. Conte is a neuroimmunologist specializing in MS care, and he currently practices at Methodist Hospital's Comprehensive MS Center in Maryville, Indiana. We're so pleased to have him join us. And Dr. Conte, I think I'm going to turn this over to you. You have your slides.
Great. Thank you so much for having me. And happy Pride, everybody. So it's the very last day of Pride Month. It's the evening of the very last day, so we're catching it at the very tail end, literally. So all good. It was a good month. Weather was very hot around Chicago. Pride Parade was yesterday. Pride Fest was last weekend. So everything's winded down at this point as quickly as it came on. Everything's good. Hope everybody's staying cool out there right now. To be honest, I didn't prepare too much for today because, lately I'm just not really sure what to talk about on this topic because stuff's moving very quickly these days, with different policies, still not that much research out there. So I've given this presentation a few times now over the last few years. This is the exact same deck I just presented about a month ago in Phoenix at CMSC. So it's basically version 4 now. And, I was mulling this over when I was invited to give this presentation about a month ago of like, what am I going to do for more of a patient-focused deck? And I just don't know what I'm going to do quite yet long term. So this is still pretty science heavy, although there's not a ton of science, just because there's not much research on this topic, which is part of the problem. But on that end, I'm just going to go through it because I think it's good to be transparent about what the science says. I think it was asked of me to really focus on science and sort of how we can sort of help patients. But hopefully in the next year or two, I will have separate decks, because more to come. So yeah, I mean, really, this version this year is different than it was last year when I presented this at conferences. And really, the big change was the first section was really actually to talk about health policy because I think it's important, especially in the US this year. There's been a lot of fast-paced policy changes as far as it, may or may not affect LGBTQ plus people, especially trans people. Then I talk about overall health disparity and minority stress theory. Talk a little bit about gender affirming hormone therapy, and just really discuss what we need in the future. So, you know, if you asked me like 2 years ago, maybe 3 years ago, I thought everything was going pretty good for the future as far as LGBTQ plus health in the US. But really over the last few years, there's been a huge rise in legislation targeting really science-based gender affirming care. And in 2021, it started really with there's actually 8 states that enacted anti-trans laws. The year later, lawmakers in at least 37 states introduced a bunch of bills restricting gender affirming care, which is triple as it was in 2021. 2023, 30 states have actually restricted access to certain gender affirming care. Obviously in earlier this year, the federal government had an executive order only recognizing two genders, which was male, female, which is kind of crazy. I mean, despite what your personal beliefs are, I mean, this is science-based, and these people do exist. There's about 1 million people in the US who identify as trans in some way, shape, or form. So sort of just to ignore those people totally, sort of wipe them from existence. I mean, they're still going to remain here. So it's just sort of, we need to think about the best way of handling this in the future because there's a lot of people, about 1 million people. per the latest, as of like 2 years ago, trends. And one thing I just want to start from the beginning is, I talk about gender affirming care. I'm not going to talk into too much detail about what that means. I did last year, but gender affirming care means many different things, right? So a lot of the policymakers are very black and white about it, but really gender affirming care means many different things to the individual. And that's really the beauty of it. It's highly individualized to the person. Each trans person really has their own goals with gender affirmation. It could be as simple as pronouns. It could be as complex as full gender reassignment surgery. Oftentimes it's somewhere in the middle. So, usually the majority are more social gender affirmation, which is changing appearance, clothes, pronouns, etc. There's actually not a huge ton that actually go through surgery, which I think is what the lawmakers are really focused on. And so what this means for the trans people, right? So the whole idea of gender affirming care has been studied over and over again. It's actually a life-saving type of, process, right? Like I said just before, means many different things depending on the person. As far as high school students go, what we see is back in 2023, nearly a quarter of this survey had high school students actually attempting suicide. This is not ideation, actual suicide attempts, okay? And the comparisons are right there, 5% cis males, 11% cis females, so much higher odds of suicidality. And then the year prior, the study showed the gender affirming care in whatever shape or form decreased the odds of suicidality by about 73%. So those are big numbers, right? And the thing is, even though I just said gender affirming care means many different things, right? So, these numbers are population level, of course, not individual level, which is an important distinction to make. But the thing is like, as the science isn't sure proved about guidelines and whatnot, yet, anti-trans health legislation is increasing across the board. And to the point where it's getting kind of crazy, in my opinion, this goes beyond personal beliefs about trans health, is that there's actually 6 states as of March 2025 that actually make it a felony crime to the physicians to provide certain forms of gender affirming care, right? So they're actually criminalizing physician, which I think is kind of crazy to think of that, first of all, government should stay out of the patient's, rooms, what I mean, our office rooms where, we really are providing services in an informed, consented way, et cetera, right? I think it's kind of crazy to totally criminalize that process, right? Debate about civil penalties of whatever issue, right? I mean, I think med mal type of processes, still stand no matter what you look at, but to actually make it a actual crime to sort of practice medicine is a bit crazy in my opinion, no matter what your belief is on this. Um, so what does this mean for the patient, right? A lot of the research is focused, this is recent data, 2020 and 2015, really the last 10 years. About a quarter of trans individuals actually postpone or avoid healthcare due to anticipated discrimination. What that means is, let's say a trans person, for example, is having, I don't know, an asthma attack, right? So depending on where they're at in the gender affirmation, it could be anywhere. They may be nervous to sort of say, like, really, is it that serious to go to the hospital for, or to my doctor? Because, I'm not used to them at urgent care. I'm gonna have to explain, the situation with hormones, whatever, like, right? So this is anticipated discrimination. Or it doesn't mean that they're actually going to be discriminated against, but it's the fear of it, right? And that fear changes our behaviors. And this applies really to any minority group, not just trans people, not just LGBTQ plus people, any minority group. In fact, to the point, right, we see even higher data for trans people of color. Um, right, so those that have a history of actually being discriminated against in the healthcare setting are more likely to delay or forego future care. So the whole story is that, a patient with a mild asthma exacerbation, for example, or whatever, then keeps delaying care, and then all of a sudden they have to call 911 and go to the hospital because they have delayed their care to a point where it turns into a crisis. From the doctor side, again, with health policy, there's still 10 states that actually have laws that allow professionals to refuse LGBTQ plus patient care. They're called the Conscious Clause Law. I did this presentation at Rush Grand Rounds earlier this year, and I actually pulled up data from, or like the law books from Illinois. Actually, Illinois is one of those states that has the Conscious Clause law, interestingly enough, right? Now, the context is that Illinois has much stronger anti-discrimination laws than this Conscious Clause laws, but it's still antiquated laws on the book, actually. Right. And so the bans on gender affirming care, it ignores, medical guidelines, right? We're just trying our best here to provide services to, the way the science is showing us, right? Nothing's ever set in stone with science. Science, I always tell my MS patients, the science builds on each other, right? But to just sort of be very black and white about this, it's just wrong. Um, and what happens is that all these bans create confusion for patients, and it creates this healthcare desert concept, right? So it forces patients to travel out of state or forego care, right? So the patients, this turns into an health equity patients, the health equity issue, the patients that have the means can travel out of state, but the poor patients who don't have the means, or the disabled patients that don't have the means, they can't get care. Right, and federal funding for research on this topic is in limbo, obviously. Right, so I alluded to this is a deck for doctors. I talked about why this matters for us as neurologists. And I think this is an important thing to say, right? So as a neuroimmunologist, I do not provide gender affirming care in the traditional sense. I do not prescribe hormone replacement therapy. I do not, I'm not a surgeon, obviously. Um, but I am a professional who provides long-term chronic care to patients that have a chronic neurologic problem, across the lifespan. And so I think we as neurologists really have this opportunity. This isn't a one-stop shop thing where, a patient comes in, gets a diagnosis and leaves, right? It's a longitudinal experience. We have opportunities to support the patients in this regard, and I'll tell you why in a bit this matters. So, right, so we are advocates. We're not just passive providers. Can either, we can combat discrimination and sort of put people at rest, or we can reinforce that discrimination, reinforce that patients, fear of discrimination, and really have a duty for evidence-based care. And I think this is important, the combat versus reinforce discrimination. Just randomly, like yesterday, my husband was saying he saw like a commercial on Instagram where it was like a Pride commercial. I don't even know what commercial it was for. But it was cool. I mean, it was really, really what Pride's about this month, and why, it's really important to continue it long term. It was like this video. He was saying it was a video of, it was basically showing like this anxiety of anticipated discrimination. It's very, it was very well done. It's like a guy on the subway who's fearful for who sat next to him's appearance, sort of stereotypical, sort of not like anti-gay person, but then he saw like a rainbow wristband, and it was like you could see this relief, right? And it was like a lesbian couple in the back of an Uber were like kind of nervous to hold hands at first, but then they saw a pride flag up, so they like relaxed and were able to hold hands and really just act normal, like a normal couple would be, right? So like that's what I'm talking about here, about this opportunity to either combat the fear of discrimination, or we can feed into that narrative on the individual that, oh, they were right, they were, their doctor's not in tune with the situation, right? So this is why it's important really for us as professionals. This has been studied really heavily in really a lot of minority groups, of that one of the protective factors against minority stress theory is inclusive healthcare practices, because patients are much more vulnerable than normal at the healthcare setting, right? So this is the opportunity. Right. And I do think, one of the issues is, and I wrote this in a recent editorial about shared decision making this past year, is that medical mistrust and misinformation is really rapidly on the rise to the point where it's even hard to continue the research on because it's moving so fast paced. We're seeing this especially in marginalized populations, however, right? Earlier this year, the AAN, American Academy of Neurology, for the first time put out a position statement talking about LGBTQ plus equity in neurology, which I think is great. Okay, so that's my I don't know, politics hat, I guess, which I honestly know not a ton about intentionally. Kind of ignorance is bliss sometimes, right? So let me segue a little bit and talk about some specific health disparities that LGBTQ plus people face. This is more in general, but it applies to chronic disease like MS as well, right? So, you know, LGBTQ plus people, higher rates of really everything, right? Just worse overall general health at the population level, right? Individually, you'll see people who are really healthy and other people who are really unhealthy. So a lot of that has to do with this discrimination piece and minority stress theory. LGBTQ plus people, high rates of actually getting slurs, hearing slurs sort of being made fun of or worse. Microaggressions, that's like low level, weird attitudes you might get. In the situation. And this data is from 2019, so pretty recent. Still, a majority of patients of people have sexual harassment in some sort of part of their life, and actually, still a majority have actual violence. Um, right. And so healthcare discrimination, this is back in 2019 as well. 18% of LGBTQ plus patients actually avoided healthcare due to anticipated discrimination. I talked a little bit about there earlier, but still a fair amount actually experience the discrimination once presenting to a healthcare setting. Higher with trans people, of course. Okay. Right. So what is this minority stress theory that I keep talking about? This is a framework that helps understand health disparities of minority group. It's been heavily researched, really, in all minority groups, but especially LGBTQ plus populations. And really, the two components of this is that there's this distal stressor and a proximal stressor. Distal means far away, proximal means close. So distal stressors, you could think of an external stressor versus a proximal stressor as the internal response slash stressor. So external stressors, obvious things like discrimination, prejudices, microaggressions, sort of just outside world stressors about being a minority person. And then what happens is proximally, there's these internalized feelings. Now, a lot of these are subconscious feelings. Now, so the subconscious is not readily accessible, so you don't really know that they're there. Okay, it's a little wonky. So these stressors create internalized stigma, concealment of identity, right? This is the whole being in the closet thing for a long time, and also fear of rejection. And what happens is it turns into this big loop, right? I should probably have a big loop animated where there's this, I mean, it's the chicken or the egg that starts. But basically, there's the distal stressor, which then internalizes in the individual, which then changes our behaviors, which then might lead to different types of external stressors, which then again pulls into the subconscious, and then it's a vicious cycle, right? And so you need to break that cycle. Is the social support theory, which I'll talk into next. So the overall burden of minority stress is determined by the negative experiences versus protective resilience. So we want high protective resilience, low negative experiences, right? Can't have 100% each, or 0 and 100, but it's the idea is what's the burden of the minority stress, right? Hundreds and hundreds, probably thousands at this point, has shown evidence that LGBTQ plus discrimination does lead to adverse health outcomes. It could be simple as interpersonal discrimination, like bullying with kids, but structural discrimination, like laws or policy, also leads into an increase in minority stress. It doesn't have to be directed against the individual, right? And this is an important point, is that it's actually linked to health harms, even for those who are not directly exposed. So just hearing about the legislation in the news, all these new policies, just really the narrative, negative narrative, that increases minority stress, right? So like, I'm not trans, but what's affecting, my trans brothers and sisters affects me because it's a stressor, right? This is a distal stressor, subconsciously goes into my mind. I mean, consciously it's like, well, what's next? But subconsciously, just hearing about stuff like this is affects really all minority groups, right? One could argue even non-LGBTQ plus minority groups are also getting these distal stressors because it's like, well, what's next, right? Um, and to that point, the intersecting identities like gender, race, and socioeconomics, it adds up. Right, so these protective factors, what protects against this is peer community and family support. This is social support theory, access to affirming healthcare, which I just talked about earlier, and inclusive practices really across the board. Okay. So like I said, for neurologists, this is where I really advocate is that, we have an opportunity here to combat this. And the thing is we know with MS patients and MS care, the higher number of health problems an individual patient has, more comorbidities, as we call it, their poor general health leads to a worse MS course overall, right? So this is why it's important for us. There's only been a couple of studies looked at LGBTQ plus things with MS, really only like three. So I've talked about this before. There was a study back in 2017, a little old at this point, from Italy, where they saw that LGBTQ plus patients were more likely to change their MS center, nearly double than other groups due to perceived homophobic behaviors. A San Francisco um, survey back in 2021, they found that LGBTQ plus MS patients had lower involvement in LGBTQ plus activities due to their MS status, and 30% felt uncomfortable discussing their SOGI status, which stands for sexual orientation and gender identity status with their clinician. And this is in San Francisco, which one, is would assume it's like a really safe place to be open, but still 30% felt uncomfortable, right? So this is why I also talk about with other neurologists about cultural competency, about sort of learning the lingo, etc. So the interesting thing about this study also was is that so basically what this means, the first part of the sentence is that once diagnosed with MS, an LGBTQ plus person felt, less comfortable participating in their general LGBTQ plus circle and vice versa, right? So LGBTQ plus MS patients felt a little bit more uncomfortable going to a general support group, right? So that they lost their circle. NARCOMS, if you don't know what that is, it's a large registry run through the Cleveland Clinic that primarily looks at patient-reported outcomes. This is a survey. They looked at this a few years ago, and they found, and it's limited data, it depends how you ask the questions is the problem. According to their study, 0.45% of the cohort identified as trans, 4.6% identified as non-heterosexual. Again, these are funny terms, but it's just based on the baseline characteristics they had. They found similar healthcare utilization between these two groups. Trans people had less comfort discussing sexual health, and bisexual people had the lowest satisfaction with care. So my criticism of these three studies is that this is all, patient-reported outcomes, sort of the experience of the LGBTQ plus patient with MS, which is great. I think we need that stuff, but where's the data looking at health outcomes of, MS patients? Do LGBTQ plus MS patients have a worse disease course? Is this minority stress, sort of low level implicit bias? Maybe are they, getting delayed diagnosis? Are they not being put on high efficacy therapy quick enough, right? So that's still up in the air, and hopefully once I get funding, I can answer that question. So talk a little bit about hormones here. I'm not going to go into detail too much. We're kind of going to fly through this. Really, the whole point of gender affirming hormone therapy, right? And not everybody who is trans goes through hormone therapy. Most do, though, eventually, is that you either use feminizing gender affirming hormone therapy or masculizing, right? Feminizing, and the whole point is that you want to develop female secondary sex characteristics. You do that with adding estrogens, but you also need to add second medicine to suppress male secondary sex characteristics. So you need to give an anti-testosterone agent too. Whereas with masculizing gender affirming hormone therapy, you just need to give testosterone supplements. So it's a lot easier. Now, estrogens in MS, this is pulled from a lot of perimenopausal and postmenopausal MS patient data. I mean, I think estrogens in MS is great. There's neuroprotective effects of estrogen. We see estrogen receptors on the immune cells. Time and time again, we see higher physical quality of life measures in postmenopausal women with MS on hormone therapy, right? This needs to be a shared decision making about risk benefits in an individual, but I think it's relatively safe to use all in all, and the outcomes are just so great on MS patients. So as I said earlier, masculizing gender affirming hormone therapy, you suppress the female secondary sex characteristics and you develop male secondary sex characteristics, but you could do this all with just testosterone. Now, testosterone in MS is very interesting. There's actually an ongoing trial in Europe looking at testosterone replacement as a disease-modifying therapy, even. They're using it in cis males with low testosterone levels, and they have certain guidelines there. But time and time again, low testosterone has been shown to actually be a risk factor for both development and higher disability progression for MS in cis males, really across the lifespan. It crosses the blood-brain barrier. It gets into the brain. It protects the cells from oxidative stress in response to the inflammation. So there's a lot of stuff about this. Now, I don't want everybody to run to their doctor and be like, I must be on testosterone, right? This is probably not cause and effect. I always talk about, there's many pieces to the puzzle with MS care, both with how MS is caused and also how we treat it, right? There's lots of little pieces to the puzzle here, but this is one of those pieces. Okay, so there is one study, and I think this goes to my point about testosterone, how important it is in the development of MS, is that there's actually a record linkage study. This is back in 2016, so pretty old at this point, almost 10 years now, so it's done in the UK, and basically record linkage study basically means is that they pull, I mean, in the UK, I don't know how they do their billing, but if it was in the US, they would pull insurance companies' codes that were billed to them, right? So I guess in the UK, it would be just one thing. And basically they associate, so they basically combined two diagnosis codes and see what is the association between them. That's sort of layman's terms and how they do it. So they found this association between gender identity disorder and the development of MS in transgender women. So basically, they saw higher rates of the co-occurring diagnoses for an individual of gender identity disorder. It was called that back in the day. Now it's called gender dysphoria, and then MS. Okay. The context here is that it was about 1,000 people they looked at, and there were 4 observed cases of MS out of that, roughly 1,100 people, it says. But the expected number of cases should have been 0.6. So then statistically at a population level, it's the risk is sixfold from not. So as I said earlier, for a trans woman, you're going to be given anti-androgens in addition to giving estrogens, right? So you're actually fully suppressing testosterone, right? So I think that's a clue here about pathophysiology with MS here, that actually testosterone is more important than estrogens as far as the pathophysiology behind MS. So this is very interesting to me. But I mean, to comment on this, right? I mean, I'm not trying to say that, oh, patients, trans women, could develop MS. That's not what I think is the conclusion of this. This is just another piece to the puzzle. We have to remember, I think these numbers are really low and that Again, it's about counseling patients on things. Right, so then I'm going to end on a good note. How we increase inclusivity over time. I mean, healthcare professionals, we do need to be collecting name, pronoun, and sexual orientation and gender identity information, right? So patients do want to disclose this information, right? Majority do not want to keep it secret. So in a study in 2018, a survey showed that healthcare professionals, 77.8% of the surveyed healthcare professionals thought patients would refuse to disclose their identities, but only 10% of patients actually refuse. So there's this huge disconnect between the perceptions of HCPs and the patients. And I think a lot of this actually has to do with a lot of the specialists. Right, I'm a specialist. I think a lot of specialists will comment, well, I don't prescribe those meds. I don't do gender affirmation. It's like, well, but you need to collect the information, right? So they think that it doesn't matter, but it actually does, as I said earlier. And the study also showed that patients prefer to disclose these things through nonverbal methods. So that would be like through the intake form, although it's hardly paper these days. They don't want, I think most patients don't want to make a big humbo jumbo about it, is my sort of thoughts about that. And, I agree with that. I think, most advocacy that LGBTQ plus people that we want is to be integrated into society. We don't want to be like in your face about it, but, we want to be normalized, right? I think, obviously there's some exceptions that people talk about, but all in all, it's just treating normally, right? So I think this is important stuff. Plus, we need to be doing this in the research studies. And then, there's some stuff I talk about with the doctors too. So yeah, future studies, I mean, to this day, it's 2025. I'm being reached out by CROs for research studies, and still none of the modern phase 3 studies for MS have sexual orientation and gender identity information in the baseline characteristics. We're not even asking the questions, right? So in the portals where we enroll a patient, it says male, female. Cool, right? Like, I mean, we need to do a little bit more granularity there. And the problem is that it has a downstream effect by not collecting the information. We don't know what the data will show, obviously, right? And so an extreme example of this by not collecting information is that it might end up in the label, right? We see this, here's some extreme examples, right? Pregnancy with MS drugs, right? Really across the board, all the drugs say, do not use if you're pregnant, right? Well, the context behind why it says that is because it wasn't studied in pregnant people, okay? Doesn't mean it can't be used in pregnant people from a scientific basis, but you see what I'm saying? It just ends up there flat out. And so, we don't see that with sexual orientation, gender identity as much, but this is an extreme example of a downstream problem by not studying this stuff. It'd be very simple to collect. But no one's doing it, even though I told them to. Here's the plan study I'm looking at. So I have a protocol I'm developing. I just need to get funding to initiate it. Basically doing two separate studies, one for MS, one for NMOSD. NMOSD literally has 0 studies on this topic. I want to look at really surveying patients, looking at their overall disease course, differences in treatment, social determinants of health of LGBTQ plus people. Right, and this last point, call to action, right? So without the inclusive research, we're only going to be continuing to provide care models based on outdated or incomplete data, right? So, maybe in 10 years from now, my study will be done and no differences. I would love to see that, right? But we need to learn, right? I mean, if you don't know, if you don't ask the question, you're never going to find out. So that's basically it. I kind of rambled too much on this, but hopefully next year I'll have, sort of a more information about sort of a little bit more fleshed out just for, what patients can do with this stuff.
Thank you. Uh, One of the topics in the panel last week was how to advocate for your body while maintaining that. Let's see.
Like, what do you mean?
Let's see. Yep. One of the topics in the panel last week was how to advocate for your body while maintaining that doctor-patient relationship. Can you give some additional suggestions on how to educate my physician and their staff?
I'm not really sure what that means, like educate about. Say that one more time. What was the terms?
I'm sorry, say that again?
What was the actual question?
I'm reading
Which
it
part?
exactly. One of the topics in the panel last week, we had a panel for LGBTQ.
Oh, okay.
Yeah, and so um, how do we advocate for your body while maintaining that doctor-patient relationship?
Okay, so I'm not sure what advocating for body means. I think I know what it means is maybe that person was a trans patient talking about their body maybe. I mean or I could be wrong. It could just be advocating for themselves, sort of
Well,
like
they also said on pronouns. So,
okay, so it must be about
right,
a trans person, how to advocate for themselves.
yeah.
Yeah. So yeah, so it's really hard. I think I don't want to like sort of make it pink washed here that you just need to stand up for yourself, right? So my experience with most HCPs is there's not too much explicit bias these days as far as minority groups, though. But there's a ton of implicit bias. Implicit bias means it's sort of in the subconscious. The person's not really aware of that bias, whereas explicit, it would be like, like a racial discrimination, for example, would be very explicit. So the HCP might not know that they're having a reaction to a certain situation, okay? Just first of all. I do think benefit of the doubt's really important, but I do think there becomes a point of giving feedback and it's not internalized, like it keeps being like a patient keeps getting misgendered, for example, or misnamed, like that becomes a problem. And one should be called out, and two, could be a termination sort of thing. There's many options these days for patients, for most metropolitan areas. Now, rural areas, I know that gets very complicated. Um, Now, so I'm rambling again. I think it gets a very delicate situation, I think, is what this person's sort of talking about. It's sort of, um, yeah, it's hard to give it advice because it's like just so depends on the situation. I think in general, you should be advocating for yourself, but you need to approach it in sort of a gentle way, right? And I think we should also, as doctors, be approaching these situations in gentle ways. So I always talk about to doctors, especially neurologists, about approaching situations with an air of curiosity, right? I think we could do that in a lot of aspects of life these days,
Mhm.
not just about this topic. And I also tell the doctors have to be voyeuristic about it, right? That it gets to be a point where you need to stop asking questions. Um, so I think you just gotta assess the situation, right? I think you need to be open and honest. You cannot be hiding stuff from us, right? Especially for MS care. We need to know everything. And I think, if there's resistance about that, that'll be very telling. I think if you're with somebody who's curious about this, you'll know right away versus someone who has you know, a reaction. Maybe it's not a bad reaction, but just sort of a reaction in general. Um, so I think setting up clear expectations is important. Being curious with them, educating them, and also seeing how things go over the next months, right? Again, if like for an extreme example, if your pronouns, um, you've stated your pronouns, right? They're not your preference. They are your pronouns. I always tell doctors that. Don't do this whole preferred pronoun thing. I always say there's pronouns, right? Um, if you're being misgendered over and over again, that's the most simplest thing, right? You know, maybe time to move on. But I know sometimes it's easier said than done. But there's a lot of fellowships churning out new neuroimmunologists every year. I think access to high quality neuroimmunologist, fellowship trained neuroimmunologists is very, in most areas is getting better and better. The rural areas still are difficult, but
It's growing.
yeah.
Numbers are growing. So, how can someone volunteer to be part of your future study?
I have no idea because the future study's not there yet. I have no, you tell me, I have no idea. I mean, it's so tricky this study. So it's going to be a multi-center study. It gets very tricky to just be out in the open, and there's different methods between this. There's different some areas. I'm hoping to do it the right way first. Oftentimes you can't do it the right way first, so I think it's some pilot data. But we'll see. We'll see how it works. I can't answer that yet because I just don't know. I literally don't know because it depends on the amount of funding I get to be what the scope of it is. Like it's gonna happen either way. You know, if I'm doing it on my own dime, it's gonna be a very small, quick study at my own clinic, right? But if I can get a ton of money, I can make it very fleshed out. Actually, give honorarium to each participant, spend
Mhm.
time with the survey or whatever I'm gonna do and flesh it out. But it comes
Well,
out to money. I
please let us know
will.
if and when it happens so that we can try to at least show it somewhere, whether it's
Yeah,
on
yeah,
social
yeah,
media or
yeah,
something to be able to help you.
yeah. Thank
So,
you.
okay, next one. Have you seen differences in how MS is reported across LGBTQ plus patients, especially in terms of mental health?
Yeah, I mean, I think it's hard to answer that because I don't want when we're talking about I think anecdotally we could, you know, stories are powerful, but we have to be careful about generalizing them to everybody, right? And so, yeah, I mean, I have stories, but like, those might be, everybody has stories, but I think looking at the population is more important from a scientific standpoint. I think, I kind of flew through it in the slide deck, but LGBTQ plus people, we have higher rates of mental health problems, not because of being LGBT, but just because of this minority stress that I was talking about. As you know, higher rates of mental health problems lead to worse health outcomes in general. Also, mental health problems lead to worse outcomes in MS care. It increases our patient symptom load because there's a huge mind-body connection. We see that time and time again, and so everything's intertwined here.
Thank you. Are intake forms or EMRs adapted for inclusive language, such pronouns and relationship status?
Yeah, it depends on the center. So I'm like, I will be honest, like I don't really have an intake form at my center. Although lately I think they are getting sent something, which I don't know what they're sending, but like, how it works, and I don't think I do this, my center does this well. It's like literally if a patient has a chart at the hospital, like that's easy, but like, patients that have never had a chart in my hospital, like they literally just go through the basics. I think they are being asked about pronouns. But I don't think they're asking it the right way. So it's very tricky. Is who's that first point of contact? Is it's always tricky, right? So I can get on my soapbox time and time again about what I'm doing, right? But the first point of contact actually is probably the most important. But usually that's not with the right person. It might be a call center person overseas. Like we just don't know. Um, I will know Epic, which is the most popular EMR at big places, I think across the country at this point, does like by default have built in all this stuff in the background. So like if you just go into my Epic My Chart, you could change it yourself on your phone at home, like just your information. Like I've done it for myself, just for like my nickname Billy. Like so actually when my doctors look at my chart, it says Billy Conte, even though my legal name is William Conte. So the legal name gets submitted to insurance and billing, but then, it says that in the chart, right, front and center. You could change your name at will. You can change your pronouns at will, right there. It asks like sex assigned at birth, president's identity. It's very fleshed out and nice actually. And it's actually brilliant the way they did it because, as I said, those studies all showed that patients want to disclose through nonverbal needs. So you can really do it once you actually have a chart
Hmm,
made for you. You can do it yourself right now. It's really easy, at least with Epic. I don't know about the other EMRs.
cool. I don't think we have any more questions. I'll give everybody another second in case they want something through, but I think you did a great job.
Well, thank you
Great
for
job
having me,
educating
everybody.
everyone. So That brings us to the end of our time. If you've missed any part of this conference, it has been recorded and will be available through the MS Focus Facebook and YouTube channels. Please reply to your registration email for information on how to access the recordings or to just sign up for our newsletter to learn about upcoming events. Also, you'll be receiving a short survey when you leave the conference. We'd greatly appreciate your feedback, which helps us determine what type of information is most helpful and meaningful to you. Our next teleconference will be Tuesday, July 1st, tomorrow, at 3 o'clock p.m. Eastern, where our guest speaker, Sherry Binns, who's not only an MS certified nurse, but also our patient healthcare liaison, will be presenting a 60-minute Q&A called Ask the MS Nurse. You can ask her all your symptom management questions. Our sincere thanks to all of our attendees today for your participation, and especially to Dr. Conte, who took time out of his busy schedule to discuss this very important topic. Once again, we'd like to thank Genentech for their support for this Pride Month educational opportunity. And I hope everybody has a great night. And thank you, Dr. Conte. We'll see you next time.
Great. Thanks, everybody. Enjoy
Bye
the
bye.
rest of Pride Month.